Hello everyone, I'm Dr. Mythri Shankar, Assistant Professor in Nephrology from Institute of Nephrology, Bengaluru, India. I'm here to talk about tumor lysis syndrome today. I have no conflicts of interest to declare. Here is the overview of my talk, the definition of tumor lysis syndrome, risk stratification for tumor lysis syndrome, pathogenesis of acute kidney injury in tumor lysis syndrome, diagnostic criteria, outcomes, prevention, and management of tumor lysis syndrome. Tumor lysis syndrome is an oncological emergency due to the massive lysis of tumor cells, which releases vast amounts of potassium, phosphorus, and nucleic acids into the blood. Tumors that have high risk to go in for tumor lysis syndrome have high tumor burden, high proliferative rate, and chemosensitivity. Tumors with high risk are malignancies such as non-Hodgkin's lymphoma, acute lymphoblastic leukemia, chronic lymphocytic leukemia, and germ cell tumors. Solid tumors and slow-growing hematologic malignancies such as multiple myeloma have a much lower risk for tumor lysis syndrome. Few other risk factors are multiple extensive meds, high intensity of initial chemotherapy, elevated lactate dehydrogenase levels, involvement of the bone marrow, spleen, liver, pre-existing renal impairment, obstructive uropathy, volume depletion, acidic urine, and nephrotoxin exposure. Tumor lysis syndrome can occur either spontaneously or after the initiation of cytotoxic therapy, but it usually occurs following treatment with steroids, chemo, or radiotherapy due to the rapid breakdown of tumor cells. Acute kidney injury in tumor lysis syndrome can be caused predominantly by two mechanisms, which are classified as crystal-mediated and non-crystal-mediated mechanisms. Under crystal-mediated, we have uric acid crystals, calcium phosphate crystals, and a phenomenon known as epitaxy. Non-crystal mediated, we have histones, cytokines, which cause oxidative injury, inflammation, and arterial vasoconstriction. Nucleic acids get broken down to uric acid, which may precipitate in renal tubules, causing acute tubular injury. Increased phosphate levels combined with calcium and deposit calcium phosphate in the kidney tubules, again causing acute kidney injury. Uric acid precipitates readily in the setting of calcium phosphate crystals, and calcium phosphate precipitates readily in the setting of uric acid crystals, thus causing acute kidney injury. This phenomenon is known as epitaxy, in which there is growth of one type of crystal over another. Calcium phosphate coats the otherwise soluble uric acid. These types of crystals usually contain a mixture of minerals. Crystal-independent mechanisms of acute kidney injury are due to histones and cytokines. Histones are found in the nucleus of the eukaryotic cells. They are basic proteins that combine with DNA and help condense it to chromatin. During tumor lysis syndrome, extensive quantities of extracellular histones are released into the circulation, causing cytotoxic and endothelial injury, leading to acute kidney injury in tumor lysis syndrome. Summarizing the important mechanisms of acute kidney injury in tumor lysis syndrome, the lysis of tumor cells releases potassium, causing hyperkalemia, which in turn may cause cardiac arrhythmias, increasing the risk for acute kidney injury. Lysis also increases the release of nucleic acids, which gets broken down to uric acid formation. This uric acid gets precipitated in the tubules of the kidney, causing acute tubular injury. Hyperuricemia is also known to cause renal vasoconstriction and impaired autoregulation. There is increase in release of phosphorus, which combines with calcium to form calcium phosphate crystals, which get deposited in the kidneys and other organs, thus causing hypocalcemia. This hypocalcemia in turn causes seizures, tetany, and arrhythmia. Other contributing factors include volume imbalance, nephrotoxins, chronic kidney disease, and obstructive uropathy. Tumor lysis syndrome can be classified as either lab or clinical. In 2004, the Cairo-Bishop classification proposed specific criteria for the diagnosis of lab and clinical tumor lysis syndrome. The lab criteria includes a specified absolute value or a 25% increase from baseline for the serum levels of uric acid, potassium, and phosphorus, and 25% decrease in calcium. The diagnosis of tumor lysis syndrome is made upon identifying two or more of the criteria proposed 3 days before or 7 days after administering chemotherapy. Clinical tumor lysis syndrome is defined as lab tumor lysis syndrome in addition to one or more of the following: acute kidney injury, cardiac arrhythmia or sudden death, or seizure. These criteria are broadly used, though there are several drawbacks, especially from a nephrology point of view. First, these criteria are defined relative to the timing of cytotoxic therapy. Hence, it does not consider spontaneous tumor lysis syndrome. Second, it defines acute kidney injury as 1.5 times the upper limit of serum creatinine, which is a poor indicator of true acute kidney injury and can include patients with chronic kidney disease as well. Third, the distinction between lab and clinical criteria is of limited clinical significance and mainly for academic interest, as most patients are initiated on treatment as soon as the lab abnormalities develop. Tumor lysis syndrome has poor outcomes if left untreated and undiagnosed. In one study from Italy, 700 patients receiving induction chemo were seen. Overall, 17% developed tumor lysis syndrome. Clinical tumor lysis syndrome was associated with a higher rate of death from induction therapy. However, patients with lab tumor lysis syndrome did not have a significant difference in mortality rate compared with those without lab tumor lysis syndrome. Also, acute kidney injury was reported to be a major cause of death alongside bleeding complications. A preventive plan should be implemented before initiation of treatment, especially in patients who are of intermediate or high risk. Intravenous hydration and the use of hypouricemic agents are the two main preventive measures that have shown benefit. For more than 3 decades, intravenous hydration has been the mainstay of tumor lysis syndrome prevention. The guidelines for tumor lysis syndrome prevention and management recommend aggressive IV hydration. This improves the blood flow to the kidneys, it increases the glomerular filtration, and promotes high urine flow. Subsequently, the excretion of uric acid and phosphorus is also increased, reducing the risk of precipitation. Although there is no clear evidence to support the choice of IV fluids, RL is not used owing to its potassium content, and bicarbonate based fluids did not demonstrate a beneficial role in reducing urate nephropathy. Diuretics may be needed to maintain a high urine flow. The recommended rate of urine output is between 80 and 100 ml per meter square per hour or 3 liters per day. Data on the type of diuretic to be used are limited. Loop diuretics continue to be the agent of choice given their role in increasing potassium secretion. Thiazide diuretics can increase the level of serum uric acid and should be avoided. Always watch for volume overload, which accompanies this aggressive hydration in patients with underlying conditions such as cardiac or kidney dysfunction. Sodium bicarbonate for urine alkalization has been widely used in the past to increase the solubility of uric acid in the urine. However, there are no studies demonstrating its efficacy in reducing uric acid precipitation. In fact, urine alkalization can increase the risk of calcium phosphate deposits in different organs, including the kidneys, adversely affecting kidney function. Therefore, use of sodium bicarbonate to alkalize the urine is currently not recommended either for prevention or for management of tumor lysis syndrome. Three hypouricemic agents have been approved for the prevention and management of tumor lysis syndrome so far through two different mechanisms. Allopurinol and febuxostat are xanthine oxidase inhibitors. They block the formation of uric acid from xanthine and hypoxanthine. Rasburicase is a urate oxidase which increases the degradation of pre-existing serum uric acid to water-soluble, non-toxic, easily excretable allantoin. Allopurinol is recommended prophylactically 24 to 48 hours before treatment initiation in patients with intermediate risk for TLS, even if the serum uric acid levels are not elevated. It has been shown to have a significant effect on decreasing new uric acid formation, but has no effect on pre-existing serum uric acid levels. Here is where rasburicase has an important role to play. However, its low cost, availability, and oral administration promotes its use in patients at low or intermediate risk for tumor lysis syndrome. Allopurinol has certain limitations. It increases the serum levels of uric acid precursors, that is hypoxanthine and xanthine, thereby increasing the risk of xanthine deposition in the tubular lumen and acute kidney injury. Second, allopurinol dosing will need to be adjusted in patients with kidney dysfunction, which can result in suboptimal dosing. Third, it is known to have interactions with several chemotherapeutic drugs such as methotrexate, azathioprine, and so on. Finally, it has been associated with severe hypersensitivity reactions such as cutaneous hypersensitivity, transaminitis, and so on in patients with HLA-B5801 allele. This is of particular concern in patients of Thai, Korean, and Han Chinese ethnicity. So it is always advisable to screen susceptible patients for this genetic predisposition before using allopurinol. Febuxostat is a newer hyperuricemic agent, also administered orally. It is a selective xanthine oxidase inhibitor with a favorable side effect profile compared to allopurinol. Dosing does not need to be adjusted in the setting of mild or moderate kidney dysfunction. It has fewer drug interactions. The effect of febuxostat on reducing uric acid levels was demonstrated in a few studies with a comparable rate to allopurinol, according to a meta-analysis published in 2019. The largest study looking at febuxostat's efficacy was the Florence trial. In this trial, the investigators compared the area under curve of serum uric acid in 346 patients randomized to receive either allopurinol or febuxostat. Area under curve was significantly lower in the febuxostat group than in the allopurinol group. The data for the use of febuxostat in tumor lysis syndrome are limited. Also, febuxostat may be slightly expensive than allopurinol, further limiting its use. Rasburicase decreases the level of pre-existing serum uric acid, as already mentioned, by promoting its degradation. It has been shown to effectively and rapidly prevent and treat tumor lysis syndrome. Hence, it is used in emergency and high-risk situations. Rasburicase was shown to reduce serum uric acid levels by a 21% margin compared with allopurinol in multicenter randomized clinical trials. A major limiting factor for the use of rasburicase is the risk of severe hemolysis in patients with G6PD deficiency. The patients requiring rasburicase should be screened for G6PD deficiency before its use, which can be a limiting factor in emergency situations. It is important to note that falsely low plasma uric acid levels can occur in the setting of rasburicase use because of the continued degradation of uric acid in the blood samples, which happens at room temperature. So this can be reduced by collecting the blood samples in heparinized tubes and immersing them in an iced water bath. Another limiting factor is the high cost. Because of this, rasburicase has been studied at lower doses than recommended, and single dose regimens have been found to be as effective as 5 daily doses. Here is a table of risk stratification of tumor lysis syndrome and the recommended prophylaxis. In low and intermediate risk, the prophylactic measures are monitoring hydration and allopurinol, and in high risk group, it is monitoring hydration and rasburicase. So, in all conditions, the importance of monitoring for electrolyte imbalance cannot be overemphasized. Similar to the prophylactic strategy, management also involves aggressive IV hydration and uric acid lowering therapy. In addition, early recognition of electrolyte abnormalities is essential and should be addressed in a timely manner. Hyperkalemia is the most life-threatening consequence. Potassium in the diet should be limited. Frequent serum potassium monitoring at least 4 times per day. Cardiac monitoring, use of potassium binders, glucose and insulin, loop diuretics, and calcium gluconate supplementation may be used. Kidney replacement therapy is the mainstay of treatment in refractory hyperkalemia. Hypocalcemia is another life-threatening complication. This risk of calcium phosphate precipitation is further increased with calcium supplementation, so that should be avoided. Hyperphosphatemia should be addressed with IV hydration. Although oral phosphate binders have been used, there are no robust data to support its beneficial role in tumor lysis syndrome. Despite all preventive and treatment measures, some patients may require kidney replacement therapy. The indications are oliguria or anuria, volume overload, refractory hyperkalemia, symptomatic hypocalcemia due to hyperphosphatemia, and a calcium phosphate product of greater than 70. In patients who have high tumor cell burden, there may be ongoing release of tumor lysis products with persistent hyperkalemia and hyperphosphatemia. In these clinical scenario, continuous modalities of kidney replacement therapy with higher dialysate flow rates may be preferable. Large studies comparing different modalities of kidney replacement therapy are required. Summarizing, tumor lysis syndrome is an oncological emergency arising from the successful treatment of malignancy. Dynamic electrolyte imbalances and acute kidney injury may occur before and after treatment, keeping the nephrologist on their toes. Rasburicase has improved the outcomes of tumor lysis syndrome. The impact of novel anti-cancer agents in patients with tumor lysis syndrome is yet to be fully understood. Prospective studies comparing the outcomes of different modalities of kidney replacement therapy are needed. Thank you.